Hi everybody, I am Dr. Pradeep Shenoy, consultant rheumatologist, addressing you from Amrita Center for Rheumatic Diseases, which is located opposite to KMC Attawar in Bangalore. In this video, we will look into management of psoriatic arthritis. Initially, we used to manage with methotrexate and sulfasalazine. As psoriatic arthritis involves both axial and peripheral joints, we used to combine both methotrexate and sulfasalazine. Methotrexate used to take care of inflammation in the peripheral joints, and sulfasalazine used to take care of inflammation in the axial joints. Methotrexate also had effect on the skin disease. So this combination was perfectly alright. And unlike rheumatoid arthritis, psoriatic arthritis has got other clinical features like nail changes, enthesitis, dactylitis, osteitis, periosteitis, and newborn formation. So these manifestations also I needed to take care. I observed that methotrexate and sulfasalazine combination were less efficacious in these extra clinical manifestations of psoriatic arthritis. And when these drugs were not very useful and when the peripheral joints remained inflamed, I used to give intraarticular injection of steroids after aspirating the synovial fluid. This also was very useful. But when then came the molecule Xeljanz, that is tofacitinib, so I started comparing methotrexate, sulfasalazine and tofacitinib. Tofacitinib is a JAK, that is Janus associated kinase inhibitor. It has got effect on the all isoforms of JAK, that is JAK1, 2 and 3, and it has got effect on the all manifestations of skin psoriasis and psoriatic arthritis, that is skin changes, nail changes, enthesitis, dactylitis, periosteitis, and newborn formation. So this combination was really fantastic. And of course, for the spine disease, I used to advise spinal extension exercises and low back exercises and aerobic stretching exercises. So when Xeljanz came into the market, the treatment was much more easier. And subsequently, there were reports that Xeljanz was associated with increased incidence of venous thromboembolism, and there were increased cardiovascular risk. But I continued treating patients with this molecule, that is Xeljanz, and patients were particularly good. But I observed one fact that the response to dactylitis, enthesitis, nail changes, and newborn formation required some more addressing. So then came the molecule, that is secukinumab. Secukinumab is a human monoclonal antibody against IL-17. It's a fully human monoclonal antibody which does not require co-administration of methotrexate, and its efficacy has been proved in the long term because it is human antibody. Human anti-chimeric antibodies do not develop against this. So this antibody is very useful. Other interleukin 17 inhibitors are brodalumab, bimekizumab, and ixekizumab. I have not used remaining three, but I have used secukinumab, which has got action on all the manifestations of skin psoriasis and psoriatic arthritis. So this is a wonderful molecule. But in patients with IBD, this molecule, that is secukinumab, is contraindicated because it flattens IBD. So in these conditions, we have to give TNF-alpha inhibitors, wherein etanercept should not be given. Etanercept, there are reports that it flattens the associated IBD. So better to give other TNF-alpha blockers. So as I said, the superiority of secukinumab over JAK is that it does not have increased risk of venous thromboembolism and cardiovascular risk factors, and it does not form human anti-chimeric antibodies, so it can be used on the long-term basis, and it's very useful in the newborn formation, dactylitis, enthesitis, and nail changes. So it's a fantastic molecule wherein the patient tolerates the drug very well. Subsequently, one more drug came into the market, that is upadacitinib, which is a JAK1 specific drug. It has got more efficacy than Xeljanz and decreased incidence of infection compared to Xeljanz. It's a JAK1 specific drug. So we have lots of drugs in our armamentarium now. Unfortunately, if somebody is having skin psoriasis and psoriatic arthritis, before thinking about alternative system of medicine, you can always come to allopathy. Please do consult a rheumatologist. Hope this video is useful for you. Thank you.